Mark Kris, again, speaking about the recent World Lung Cancer meeting in Singapore. I think one of the, I'll call it hot topics at that meeting was perioperative therapy. Some information presented, some being available, presented in other forums. A couple of recent developments. I think the big news is one from Genentech, a press release saying that their trial of giving adjuvant alectinib to patients with ALK-positive lung cancer was positive. This was an advisory to advice to investors. I think it's advice to us. I think the data is very, very clear that the adjuvant therapy after chemotherapy for ALK-positive disease is going to change, and I'd urge you to think about giving these patients alectinib. Again, the benefits from a checkpoint inhibitor are very small after chemotherapy in patients with ALK-positive disease. For EGFR mutant disease, again, I think the data is very clear. We saw a presentation at ASCO about improvements in outcome. But one thing I want to focus on in those presentations and in the papers about using osimertinib is the role of chemotherapy. I think many people are saying that, perhaps you don't need chemotherapy, but the data in those papers is very clear that if you add chemotherapy to osimertinib, you improve the 5-year survival by 7%. Now that's a big number. Remember, all we've been able to do before was improve it by 5%. We're now improving it 7%. And again, the overall survival at 5 years was 87% in that group of patients. So clearly, in addition to osimertinib be given to every patient with EGFR mutant disease after their surgery, it should be given to them after chemotherapy. Obviously, if chemotherapy can be safely given. I think in those situations where you cannot safely give cis or carboplatin with pemetrexed, then it would be reasonable to give osimertinib alone. However, chemotherapy should be given. A couple other pieces of information in and around the meeting. One was Sanjay Dasik for the ISLC reported their ISLC's pathology committee work looking at the comparability of pathologic reading for pathologic complete response. What she found was very, very good correlation among pathologists from around the world. So when a pathologist can say that there's a pathologic complete response, I think that's a very reproducible fact. And Dr. Dasik's presentation at ISLC showed that. Also, the information now, there have been 5 publications, comparing chemo alone to the combination of chemotherapy plus a checkpoint inhibitor at the time of diagnosis. Every one of those shows an improvement in major pathologic response, complete pathologic response, progression-free survival, and a landmark 2-year progression-free survival. It's unbelievable that 5 trials from all over the world reach the exact same conclusions, and I urge you to think about using a checkpoint inhibitor and chemotherapy as neoadjuvant therapy for every patient that you see with stage 2 and 3 disease at the time of diagnosis. A huge issue that has come up, and it continues to come up, is this issue about should you give upfront surgery followed by chemo, followed by adjuvant therapy. People show the adjuvant data. They say, look, we have good adjuvant data here. But please remember that we are talking about different patients. Remember that adjuvant data is obtained from patients not at the time of diagnosis, not with clinical stage 2 or 3 disease, but with pathological stage disease. These patients have already been through surgery. Many of them been through chemotherapy as well. And that's a different group of patients from the one sitting in your office with newly diagnosed clinically stage 2 and 3 disease. The truth is no data available, and I don't see any data becoming available. And I urge you to focus on the data that we do have now, 5 presented or published randomized trials saying that upfront chemotherapy with a checkpoint inhibitor improves progression-free survival and pathologic response, which likely is a good surrogate for even longer-term outcomes. So there's a lot of data out there now. I do think it needs to be a change in attitude to put neoadjuvant therapy on the table for every patient. That's where the data is. There is no data for that patient about not giving them neoadjuvant therapy and instead giving them surgery followed by chemo, then adjuvant therapy. Remember that, please, when you make those decisions. And it's very nice that we have these things to offer to our patients, but it's a lot tougher for us and tougher for the patient to know how to move ahead. So please pay attention to the data we have. Think about neoadjuvant chemo and immunotherapy for every patient with stage 2 and 3 disease that's a candidate for surgery.